I'm going to go ahead and bring on our next speaker from Replimune to talk about their data that was presented at ASCO this year. Dr. Olsen-Brown, thank you so much for being with us.
Thank you so much for the invite. I'll just share my screen. So as I said, thank you so much for the invite. I'm Anna Olsen-Brown. I'm an oncologist, medical oncologist based in the UK, and worked with Replimune on a number of their oncolytic virus studies. So I'm just going to give a little bit of background around oncolytic viruses in general, and then talk about a study that was presented at ASCO this year. Is my disclosures. So obviously throughout this entire really frankly amazing webinar, we've heard about all different types of therapeutic approaches to managing ocular and uveal melanoma. And I think one of the things that's always really important is that we understand and have a sort of moment of reflection on how quickly this field is expanding, particularly thinking about how we sort of diversify and harness the power of the immune system to try and treat in as we've heard, the neoadjuvant, adjuvant and metastatic setting. And oncolytic viruses are one of those subgroups of therapies that we are working very heavily on to try and understand where they might have a role in the management of multiple different malignancies, but that actually includes uveal melanoma. And when we think about how oncolytic viruses work, essentially they actually do a number of things. So the virus I'm going to talk about is something called the RP2 virus. But it's based on the principle that oncolytic viruses can infect malignant cells and cause direct cellular destruction, but also that leads to a series of other downstream events, which essentially leads to recruitment and efficacy of CD8 T cells, probably amongst other immune cells that we can also cause optimal recruitment via the introduction of an oncolytic virus. Generally speaking, at the moment, and certainly the virus I'm going to talk about is directly injected into an area of tumour, and it causes these localized effects. And certainly the viruses that we've been working on have been used in combination with checkpoint inhibitors in the aim to optimize that immune response. So the virus sort of allows direct effects on the tumour cells, but also T cell recruitment, with the principle that if we add a checkpoint inhibitor, we actually have an upregulated, much less inhibited T cell that arrives and is much more able to be efficacious in the tumour microenvironment. So there are multiple different downstream effects of the oncolytic virus, as well as the viral effect itself, which is quite amazing. And this has been trialled in a number of different settings so far. And this is a Replimune trial looking at actually using the RP1 virus, which showed that it was very useful in the setting of PD-1 failed treated cutaneous melanoma, and we saw some really promising signs of efficacy there. And so the question was, could we put that and introduce that into uveal melanoma? So as we've talked about throughout the day, the kind of the complexities of the uveal melanoma malignancy, particularly in the metastatic setting, we know that it's a very challenging malignancy to treat, and it doesn't respond in quite the same way as its cutaneous counterpart. But also there are different immunological issues with uveal melanoma in the metastatic setting. It's quite a cold tumour. It's quite difficult to get T cells and other immune cells into the microenvironment. And also understanding whether those T cells are efficacious once they get there is also a challenge. So trying to sort of address some of those issues has led to the development of a series of oncolytic viruses, but this one is called the RP2 virus. It's a genetically modified HSV1 virus that has got a number of different mechanisms by which it can optimize its immune modulation. And that includes for the RP2 virus, this sort of anti-CTLA4 antibody-like molecule, which allows some initial checkpoint antagonism as part of the viral cascade. So the hope is that this would be seen to show some efficacy in the metastatic setting. So thinking about patients with their metastatic disease. This is going on to form part of a bigger body of work that Replimune are undertaking with different oncolytic viruses, different versions of the same base, looking in various different settings. And there is a planning underway to do a bigger uveal melanoma study. But this is the sort of the data from the phase 1 trial, which was a solid tumour trial, but we were going to look specifically at the uveal melanoma cohort within that trial. And this was presented at ASCO this year by my colleague, Dr. Sacco. So if we think about the design of this study, there were 2 parts to the study. One was a monotherapy dose escalation and a dose selection part, and then that went on to a second part of the study, which divided into 2 cohorts, cohort A and cohort B. And really the difference between the 2 parts of the second part of the study was when you would introduce the checkpoint inhibitor. Did you need that up front? Or can you introduce it later on with the same outcome? And we're still answering that question. The study's still ongoing. So RP2, as I said, is an oncolytic virus. It's directly administered into the tumour, and it can be administered either to subcutaneous or superficial lesions or to deep and visceral lesions using image guidance. And that was either via CT-guided injection into the liver, predominantly, or ultrasound-guided injection into any lesions in the liver. Patients were included if they were over 18, if they had advanced or metastatic non-neurological solid tumours, including a uveal melanoma cohort, and that they had progressed or couldn't tolerate standard therapy. They had to have at least one measurable and injectable tumour of more than or equal to 1 centimetre, and they had to have an ECOG performance status of 0 to 1. Patients were excluded if they'd had prior treatment with oncolytic viruses, if they had a history of hepatitis B, C, or HIV infection, or if they'd had any active significant hepatic infections or prior complications with HSV1. If they had active brain metastases or meningitis from secondary to malignancy, or if they've had major surgery less than 2 weeks prior to starting the study drugs. And the primary endpoint was the safety and tolerability of the virus plus or minus a checkpoint inhibitor, in this case nivolumab, that was tracked as standard, looking at AEs, and the overall response to the virus plus or minus the nivolumab. Secondary endpoints were duration of response, complete response rate, disease control rate and progression-free survival, and the 1 and 2 year overall survival. And then we, as part of the trial, we wanted to understand the biomarker elements of this. There was a large translational component to this, with multiple biopsies taken as part of the process, and there were optional biopsies as well to try and understand what changes the treatment was affecting within the tumour microenvironment. And I'll talk a little bit more about that towards the end. So in terms of the demographics, I think that there were the RP2 monotherapy arm. There were 3 patients with uveal melanoma, and then the RP2 plus nivolumab second phase there was 14 patients. Essentially, the monotherapy to phase 2, there weren't any really notable differences. But it's really, I think the thing that's really key is the fact that most patients had prior anti-PD-1 and anti-CTLA-4 in their treatment prior to being given this treatment in combination with nivolumab in combination with the RP2. And overall, 17.6% of patients had received more or equal to 3 lines of prior therapy. So these were heavily pre-treated patients, and the majority had also received this combination of PD-1 and anti-CTLA-4. If we look at the clinical activity, which is essentially where we're looking for early markers of clinical activity in this patient group, did we see any, was really the fundamental question. Interestingly, we saw an overall response rate of 29.4%, all partial responses, and a disease control rate of 58.8%. The median duration of response was 11.5 months, with a range of 2.8 to 21.2 months. And you can see that broken down here in the table. The responses were, interestingly, we found, were observed for both HLA-A2 positive and negative patients. And obviously quite a lot of the work that we're doing in the immune space in the uveal melanoma is focused on the HLA-A2 positive group. So we wanted to see whether actually we could see activity in both of these groups, and there was in fact activity seen. And this just breaks it down in terms of visuals for you. So you can see that there were 5 patients that showed a partial response, and a further 5 that showed stable disease over time. And actually what we're really looking for is whether we see responses in the injected and the uninjected lesions. And this is a really key question for us with oncolytic virus therapy. Can we essentially show antigen presentation that leads to further T cell recognition of other areas that will lead to response in the non-injected lesions? And you can see in this patient here who had a partial response, you can see responses in both the uninjected and the injected lesions, which is important to notice that we do see this sort of more sort of abscopal effect, and again you can see that as well. So when we're thinking about the clinical responses, we also want to see what's happening at a more baseline translational level, because that will help us understand how we can then potentially coordinate and build on these results. So what we did here is we took biopsies at baseline screening and at day 43, and we stained for CD8, which is a marker of T cell presence, and PD-L1, a marker of immune activity. And you can see that these change over time, that the tumours become more infiltrated in response to the injections, and also there's a higher expression of PD-1, which would suggest that there is a more sort of immune environment. Interestingly, we also looked at T cell receptor sequencing within PBMCs within the peripheral blood, looking to see if we could see a response in the sort of the circulating immune cell repertoire as a response to treatment. And we can see that there are significant expansion and new clones. There was some clones that got smaller, but actually there are, as you can see, a lot of blue blobs on these curves, which showed that numerous clones exhibited expansion that were first identified on day 43, so after the sort of the implementation of treatment. So we can see that this therapeutic combination is leading to immune activation and actually seeing benefit. One of the things that was interesting is we didn't necessarily see that this clonal expansion correlates to clinical response. So that means that there's probably more work that we can do, and probably with additional agents or different trial design, to actually understand how that will lead itself to leading to clinical response in all. But actually just seeing the fact that we see those changes means that these therapies are immunogenically active, which is really reassuring at this stage in the phase 1 trial. The safety profile is also quite interesting. So as you can see here, there were some patients who got toxicity. The most common were grade 1 or grade 2 in the groups were pyrexia, chills, fatigue, and hypertension, and some people also got itch with pruritus. There were 2 cases of grade 3 hypertension, but both were transient and regularly managed with fluid therapy alone. And there were no grade 4 or 5 AEs, which again is quite relevant. Interestingly, given the fact that the majority of the patients in the RP2 plus nivolumab trial also didn't experience any particular immune-related adverse event toxicities, is really quite noticeable and suggests lower rates than we would do with nivolumab therapy as a single agent, which is quite interesting at this point. So in conclusion, we see that RP2 monotherapy and RP2 plus nivolumab therapy resulted in an overall response rate of 29.4% and a disease control rate of 58.8% in a cohort of patients with metastatic uveal melanoma who had been heavily pre-treated, and they showed durable responses and a favourable safety profile. We saw this activity regardless of HLA status, which I think is very reassuring for that patient group that don't have a HLA-2 positivity. And it doesn't seem to be specific to a prior ICI regime. Essentially, patients could have already been treated with an anti-PD-1, and we would still see a benefit in this setting. And we saw responses in both the hepatic and extrahepatic metastases and injected and non-injected lesions. So we're seeing quite a lot of activity across the metastatic repertoire even in those patients who've had only a small number of lesions injected. We do see increased immune infiltration, and we see increased PD-L1 expression in tumours. And we see also there's changes in the peripheral T cell repertoire, which is useful in understanding the fact that we see different T cells being expressed and expanded, but also we have a peripheral marker of potential immune activation, which is useful in patients generally, and possibly has some clinical translatability further down the line. This suggests that this intratumoral oncolytic immunotherapy, with this expression of this anti-CTLA-4 molecule as part of its genetic modification in combination with this checkpoint inhibitor, has the potential to provide clinically meaningful benefits and a favourable toxicity profile. And therefore, we're going to Replimune are taking these forward and developing a more advanced phase 2 trial. So essentially, we see really notable objective response rates and disease control rates, and patients don't appear to exhibit particularly concerning safety profiles. And obviously, Replimune will be more than happy to take any requests for further information, and their emails at the bottom of this slide. I'm going to stop there.